Hey, surgical ICU team. This is Mike Kellner. I've been on the surgical ICU for the past few weeks and I've enjoyed it very much. Here's a little topic. I wanted to talk about ultrasound. I'll talk about lung ultrasound specifically. I think it's a really useful tool, not only in the emergency department where I normally work, but also in the ICU or really anywhere else you're going to practice medicine because it's fast, it's easy. Um, for a lot of things, it's actually a much better exam, more specific, more sensitive, and it's under your control so you can do it repeatedly as the patient is changing, getting better or worse, and you can record it to show other people um, your findings, unlike a stethoscope or some other physical exam finding. Um, One way that I like to stay up to speed on ultrasound and continue learning is through the ultrasound podcast. It's free. It's actually a video podcast. You can download it on your iPhone or whatever, or you can get it online.
If you're not good enough at ultrasound, that's not an excuse to punish your patients with radiation. Get out there, ultrasound some hearts, some lungs, some IVCs. Let us know how you feel about it.
He's slightly intoxicated. Got his wrist pain by doing over-aggressive high fives to his buddies.
Pretty funny ultrasound podcast. I highly recommend it. So I think that ultrasound is most useful when we're for lung ultrasound, when we're looking for B lines and when we're looking for pneumothorax. There are many other things that you can look at the lung for, like pneumonia or other things that are more advanced. But I think B lines and pneumothorax are the easiest. And B lines, looking for this exam takes about 10 to 15 seconds once you have the ultrasound at the bedside. What do B lines look like?
These bright hyperechoic things that are coming down off the pleura, moving with respiration, erasing A lines, and going all the way off the screen. Those are B lines. So how do you define a B line? It has to be hyperechoic. It has to be bright. It has to start at the pleural line. It can't start superficial to the pleura. That's gas in the soft tissue. It has to start at the pleural line. It needs to move with respiration, and it needs to go off the screen without fading. And you'll see a lot of people talk about, the depth has to be 18 centimeters or 16 centimeters from this study or that study about how the B line had to go all the way off without fading. It needs to go far enough off to erase the A lines, right? I wouldn't get hung up on depth. That thing needs to go off the screen without fading. If you're convinced that that's what's happening, you've got enough depth to call it a B line. And it has to erase the A lines. Now, I put an asterisk there because some of the lung sonography experts will say, you can't have an A line pattern and a B line pattern. It's got to be just one or the other. You'll see times where it kind of looks like there's both, in which case you pick the one you think it more is, okay? So everybody sees that. Coming down from the pleural line, erasing A lines, moving with respiration, they're hyperechoic, they go off the screen. What about this? Sliding or no sliding? Do you see any B line?
All right, so that is a B line. What's the significance of a B line?
They tell you that there's thickening or fluid in the alveoli or in the interstitium. All right, that's a broad differential of stuff. That could be pulmonary edema, especially if it's bilateral and diffuse B lines everywhere. That could be lung contusion if it's focal in a trauma patient. You've got some fluid in the lung. Pneumonia can look like that. ARDS can look like that. Pulmonary fibrosis, any kind of thickening of the lung, thickening of the interstitium.
All right, so it can be a lot of things. But so how useful is it exactly? Like when I'm in the emergency department, I typically use this for people who are short of breath and you do not know if it's CHF or COPD. This is, I think, the most useful test in differentiating between these two clinical entities. And
rule in or rule out CHF. So can't use wheezing, can't use crackles.
Oh, hang on. So looking at likelihood ratios for all of the different tests you can apply to try to figure out what is going on with a patient, specifically looking at the differentiation between COPD and CHF.
I want you to look at something in particular, something I like, when it's the likelihood ratios. Now, Matt, you know what a likelihood ratio is, right?
Of course I know what a likelihood,
All right, so maybe not 100%, but I'm thinking likelihood. It's probably like something to do with Facebook.
Right, it's how many likes. It's how many likes a certain test gets.
Facebook.
It's a Facebook thing, yeah. Actually, what it is it increases and decreases your probability of a patient having a disease after you apply a certain.
Oh, this is different
So
likelihood.
that's what you meant, right? You meant this likelihood ratio. Got it. All right. So the likelihood ratio, you have your pretest probability, and then you apply a test, and it increases or decreases your likelihood of the patient having a disease after you apply that test. Now, a good positive likelihood ratio is greater than 10, and a good negative likelihood ratio is less than 0.1. So let's look at these likelihood ratios for physical exam. Positive likelihood ratio of 0.6 to 4. 4 is the best the physical exam does, and it's significantly lower than the 10 that you need to actually be able to use it clinically.
Okay, so those are likelihood ratios.
4 is actually the elusive S3, which how many times have you heard an S3 on a patient?
A fair amount. What?
Now, what about the chest x-ray? How well does a chest x-ray do? Now, that same study looked at the chest x-ray, and we got some numbers here. A little bit better. Positive likelihood ratio of 2.3 to 6.5 with a negative likelihood ratio of 0.95 to 0.43. So positive likelihood ratio, we're getting a little bit closer to 10, but we're not quite there yet. I mean, 6.5 is better than the 4 that physical exam had, but still not all that great. Now, what about the BMP? And you can definitely, I mean, I've seen it. You have wheezing in a CHF exacerbation, and you can have crackles in a COPD exacerbation. It definitely happens. Now, how do you think ultrasound does as far as likelihood ratios?
I'd say a little better.
Yeah, it does just a little bit better, just barely better. So ultrasound for CHF was found in this meta-analysis in 2014 to have a positive likelihood ratio of 12 and a negative likelihood ratio of 0.06. So this, according to the literature, is actually nearly perfect test for diagnosing CHF. Because remember, you need a positive...
It's crackles. Not Norwegian candy, it's crackles.
You have a positive likelihood ratio greater than 10 and a negative likelihood ratio less than 0.06. Really good numbers here. Now, this is a meta-analysis that was done in 2014, and what about that study that we just looked at, with all the history and physical exam, the one with a bunch of patients? They looked at ultrasound as well, and they had numbers that weren't quite as good. They had a positive likelihood ratio of 7.
Still pretty good.
I use ultrasound in the undifferentiated shortness of breath patient is differentiating between COPD and CHF, which is a lot of our patients here in Kentucky, right?
Hey, Jacob, you ever heard of wheezing and crackles?
I've literally heard them before.
And I don't know did they teach you physical exam in your med school? I'm not sure where you went, but
So ultrasound is obviously better than using a stethoscope to try to diagnose CHF versus COPD. Now talking about pneumothorax. Looking for pneumothorax in the decompensating ventilated patient.
Decompensating. Patient is doing bad, is hypotensive, is tachycardic, not doing well. So what do? Because you're a good clinician, you go through your dopes mnemonic, displacement, obstruction, you check for pneumothorax, you auscultate both sides, you unplug them from the machine, so that's the E for equipment, and the patient, the S stands for stacked breaths. The patient isn't an asthmatic or anything like that, so it doesn't really matter, but you do it anyways, and nothing works. The patient continues to do bad. I mean, she's about to code. So the patient's doing bad, and you've really done everything along your algorithm, but you decide, hey, this looks like it might be a tension pneumothorax. I'm going to go ahead and do bilateral finger thoracostomies. This left side, you get nothing out. Right side, huge gust of air, and within seconds, your patient improves. Now, why did that happen? Why did this clinician who was experienced, knew what they were doing, why did they miss that tension pneumothorax?
Is it because the supine chest x-ray in a trauma patient misses about 30 or so percent of pneumothoraces?
Yeah. Should we just stop now and just not go forward?
No, go ahead.
Well, we can stop. I mean, that's basically it. Should we just stop?
All right. Tune back in next time on the...
So the reason that this experienced clinician missed it is because the physical exam and the chest x-ray don't always do all that well, especially in supine trauma patients. The sensitivity of auscultation for diagnosing pneumothorax ranges from 50 to 62%. Coin flip territory, once again. The chest x-ray does a little bit better, at least the upper limit of the range does better. The chest x-ray ranges from 28 to 75% sensitive. And let's compare that to ultrasound. Boom. Ultrasound sensitivity, 86 to 98% sensitive. These are really good numbers. And these last two, the chest x-ray versus the ultrasound, are based off of 4 meta-analyses that have been published over the past few years. So big difference in numbers here.
So we didn't talk about why or exactly how to do the ultrasound of the lung looking for pneumothorax, you use the linear probe, not the phased array probe, but the linear, and look for lung sliding. But running out of time here. So basically, I think lung ultrasound is incredibly useful. I think it'll be incredibly useful if it's used more in the surgical ICU. The most basic things I think we can start by learning about is looking for B-lines on the ultrasound and looking for pneumothorax, especially in the ventilated patient who's quickly decompensating. I think a curvilinear probe would make the lung exam a lot easier, as well as a couple other exams that are very useful with ultrasound. And I think if we start to get a continuous education program in place up in the surgical ICU, it'll be beneficial for ICU PAs, the residents that are rotating on the service, and just patient care in general. So thanks so much. I enjoyed my time at the surgical ICU this past month. Thanks a lot.